part 3, Dr. Grummons. This is truly a learning experience. You're going to go over more about class 3 malocclusion, the protraction face mask, or some people call it the reverse pull face mask or reverse pull headgear.
We don't call it headgear.
Don't put the word headgear in there. Okay.
Please not. Yeah, because people still will search online thinking it's that classic traditional headgear. And so we want to distinguish that. We know we're treating with class 3 midface deficiencies, but we want to expand the definition more. Craniofacial, respiratory, nasomaxillary, facial, orthopedics. It's a whammy of good stuff that we're doing as a team together. 83% of these patients tend to have a midface deficiency, nasomaxillary skeletal deficiency with the other associated problems in airway and breathing and posture and malocclusion, all the other things, facial function, self-esteem. At the top priority is the breathing and sleeping. Certainly there's an underbite, there's a dental aspect, skeletal aspect, and there's overclosure of the mandible, which often isn't talked about either. We're going to attack the width first, the vertical second, and the length third. The maxillae are the template for the mandible, for where it functions, where it suspends, where it ultimately is placed, and more. Not always does it need face mask for sure. We know fixed and rigid versions produce the most sutural change. And there's heavy elastics because for orthopedics, the traction tends to be heavier. And for orthodontic purposes, smaller, light elastics move teeth and influence their positions. But for orthopedics, the force load gets heavier.
Are there any retractive qualities because you're using one jaw to move the other?
The lower muscles immediately respond. When there's any elastic traction or anything altering the posture of the mandible, there's a triggering effect on the statutory muscles to help support the mandible in its posture. You're right, technically, but the net effect is that the upper jaw is going to change more than what the lower is, but it's not our favorite because if there's any kind of TMJ compression issues or instability, then that triggers a reason to not use it. 20 years ago, the attack was usually that the mandible was too big, was overgrown, so the mandible got corrected to a deficient midface, and it was very unfortunate. And it taught me early on that we're not treating the right part of the problem here. About 83% of these class 3 mismatches are some degree of maxillary deficiency, and primarily that. And there's a lot of dental alveolar compensations that further make the problem. The typical thing would be seeing the patient as young as we can, which is the 3 to 7 year old, and that's where we really can do a lot for people. We also have learned over the years that we want to go slow. Slow has given us more change in the nasal aspect, more change that was permanent. So slower means maybe a turn every other day, or a turn every third day, or maybe 2 turns forward and 1 turn back. The strategy is that we want to keep those sutures in disjunction and disorganized, immature for a prolonged period of time. A key thing is when this whole nasal maxillary complex comes forward, the adenoid region is actually increasing space. There may be some shrinkage, but at the same time, we're going to gain some area by relocating the anatomy. We don't use any chin loading. I could go deep with TMJ explanations. One of my colleagues in Japan followed patients who had face masks with chin cap and then followed the TMJ changes in those patients and then followed them to adulthood. And 24% had internal derangements and frank dysfunctional problems. So there is an intercapsular effect, and we don't want that. If people aren't following their patients to maturity and knowing that or having some effort to study them, we probably don't know that. We presume they finished well and they went on their way, but a lot of those patients have troubles. I learned that the malar and the zygomatic region matures very young because we want to protect the eye. Both arches can actually be relocated forward, helping the tongue space, helping the airway, the smile projection, that look where it just lights up when the person smiles. It's not only just numbers that are different, there's ratios that are different with facial types. And then when we go to numbers, you'll hear colleagues put out a number saying, we know the normal should be 37 intermolar width. Wait a second, when we go to the different facial types, that actually is a median number, but if you actually go to the brachy faces are bigger and wider. We really need to take into account the different facial type we're dealing with and then what the optimums for that patient. We don't measure to fit to the number, but we want to appreciate what is the deficiency and then how much have we improved it. And we want to have tongue space. So no matter which of these methods, no matter where your philosophy is, ultimately we want to make more airway and tongue space.